So, sorry for the technical glitch. As Jimmy said, this topic will be shared by Jimmy and Omar. I'll quickly try to go through bone graft and bone substitute. It's a wide topic. However, I'll try to summarize as much as possible. And Jimmy will give us some clinical uses. Just a bit of history. In the early Greeks, there were some cases reported whereby they tried to use ivory in the son of Tantalus when he had a fracture in his shoulder. The Aztecs were also reported to have used wooden stick to insert into the medullary canal for fixation of fractures. In the 26th dynasty of the ancient Egyptians, some cases of pure iron was used as a prosthesis. That was quite a long time ago. Recently, in 1668, Van Meckeren performed the first bone graft using a canine xenograph to repair a cranial defect of a soldier who was injured during the war. McEwen in 1881 used a fresh bone allograft from a live donor to reconstruct a humeral shaft of a child with osteomyelitis. Duhamel in 1743 noted that the periosteum has a pivotal role in osteogenesis. This is just a summary of some of the history. It's quite a big history. Going to the topic, a bit of background about bone grafting. Approximately 2.2 million grafts are done yearly, and the industry is quite big with over worth $2.5 billion. Some of the uses include to fill cavities or defects resulting from cysts, tumors, or trauma. It can also be used to bridge joints and provide arthrodesis. It can also be used to bridge major defects or establish the continuity of a long bone. In some of the situations, it can be used to promote union or fill defects in delayed union, malunion, fresh fractures, or even osteotomies. There are three properties of a bone graft. One is osteoconductive, in that the bone graft itself acts as a structural framework or as a scaffold for the bone to grow. This includes mineralized bone matrix. The other properties include, osteoinductive property, in which by the factors that stimulate bone growth and induce the stem cells down a bone-forming lineage, BMP being the most common. We also have osteogenic properties. This include cells that will give rise to the osteoblasts and osteocytes. Examples include fresh autograft and bone marrow aspirate. This is just a summary trip of bone graft and bone substitute. We'll go into details. The stages of bone grafting are 5. We have early inflammation, osteoblast differentiation, then is osteoinduction, osteoconduction, and finally remodeling. The final process can take years. Going into bone graft, we have autograft, which can be divided into cortical cancellous, corticocancellous, and vascularized pre-tubular graft, being an example of one of them. Advantage of an autograft is that there's no immune reaction and it has all the 3 properties present. The disadvantages include limited quantity, requires additional surgery, it's not easily available for further surgery. There's also increased mobility from harvesting the graft. There's a risk of infection involved, and some of the patients may have chronic pain and cosmesis issues. I've tried to summarize, this table has tried to summarize bone grafting. As you can see, vascularized graft has all the three properties, and on top of that has a mechanical property. Now we'll go to the bone substitutes. We have natural or synthetic or composite of both materials. That's a combination of different types of materials. The ideal bone graft substitute should be one, biocompatible, bioresorbable, osteoinductive or osteoconductive, and similarly structure similarly to the bone. Advantage of this include that it eliminates the donor site morbidity. It tackles issues of limited supply. The disadvantages include immune reaction, risk of infection, disease transmission, and also reduced osteoinductivity and osteogenicity when it's being prepared, and of course some ethical issues. Laurensin et al. Proposed to classify these materials into 1. Allograft based, this include DMP, factor based, such as TBF or bone marrow BMP, sorry, or platelet growth factors. He also classified into cell-based. This includes the mesenchymal, in which they will further differentiate into osteoblasts and osteocytes. We also have ceramic-based, example being the calcium sulfate, calcium phosphate, or hydroxyapatite. And then finally, into polymer-based, such as polyglycolic acid, or combination of both collagen and hydroxyapatite. This is just a summary table of the bone substitutes. As you can see, we have cell-based being the only osteogenic because it has the cells that can induce osteoblasts and osteocytes. Majority of these bone substitutes are not used alone. They can be combined with structural allograft, in that you take the scaffold and then you can add on osteoinductive properties. Then that's it. That's a summary of the presentation. Dr. Jimmy will give clinical scenarios. Thank you so much.
Hi, Omar. Well, thanks a lot. That was nice, short and sweet.
Thank you.
Right. So for the guys in the audience, this tutorial for me, it's time for us to refresh what bone graft and bone substitute is and to know when to use them. What are the advantages and what are the disadvantages? So I know Omar has kind of quickly brushed through it all. So for tonight's lecture, in my mind, your objectives when you're coming to this tutorial, if I were in your shoes for this tutorial, my objective would be to define the properties of bone graft. So that would be my first objective. Once I know this, I keep it in my mind and I don't forget it again. And I'm ready to go. The second objective for me when I was thinking about the topic, by the way, I don't have PowerPoint presentation. It is a discussion and we will be going through it with some questions in the audience. So the second objective, looking at this tutorial, it will be to actually know what are all the options. Omar has gone through it very quickly, but we can talk about a lot of things about the options that are available as bone graft and bone substitute. It is a discussion now. If you want to interrupt and ask a question, just raise your hand. You can all unmute now. If you want to talk, just unmute, talk. I'll stop and then we discuss. Is that right?
Yes,
okay.
Jimmy. Thank you.
Okay, cool. So we have to know all the available options. And number 3 would be to know actually the clinical use. So we'll give some scenarios and just to get ideas when to use what. And then The next thing would be actually at the end, we will still have to establish what is the gold standard today when we're talking in terms of bone grafting. So Omar has spoken about the properties of bone graft. The best bone graft we want to have has to be osteoinductive. I don't know if you will remember what Omar has said, but osteoinductive means that this bone graft you're using has some cells, has some proteins which we would call bone morphogenic proteins or transforming growth factors, other factors like insulin-like factors, which are able to pose influence on the undifferentiated pluripotent cells, which can then transform into bone-forming cells. That is osteoinductivity. And then osteogenetic property means that you have cells that can actually form bone in your bone graft, not just influence other cells to make bone, but those cells are available and they can readily make bone. That's osteogenetic property. And osteoconductivity means that your bone graft has a porous surface, which will act as a bridge, which will act as a scaffold where bone osteoblast can actually travel through and make bone through. So there has to be some porosity in your bone graft. And the other important factor, another important property that we actually need more often is the structural stability of the bone graft. Your bone graft must be able to withhold certain strain when it's being loaded immediately after grafting. So you do need that as well as property of your bone graft. Now, when you look at the option available, we're starting off with an autograft. So who is not looking at me? Let me go through here. Ashley? Ashley,
yes, hi, Jimmy.
You
Yes,
did.
hi, Jimmy.
Right?
Yes.
Please give me some example of where you can get autograft bone graft.
You can get from the fibula. That's one option.
Okay, so you get a fibula strut. That's good.
Mm-hmm.
Can you give me another one?
You can get for the pelvis.
Yes, so you get an alia crest. That's very good. Where else can you get autograft?
I think you can get from the radius also. I think
you can get from the distal radius. Very good. Where else can you get?
calcaneus.
You can get from the calcaneus. That's very good. Where else? Okay, you can get also from the proximal humerus. Okay, so depending on where you're operating, you may choose to go from one side to the other, also depending on how much you want and what actually you want from it. If you just want you're fixing a distal radius non-union, you don't have much of a defect, but all you want is some osteoinductivity and some osteogenetic properties. You can just get some from the distal radius itself. You just get a little bit of cancellous bone from it and you have it all. So the bone graft, which is an autograft, will give you all the properties and you will just play and see what you need. So it will be osteoinductive because it will have BMPs in there. It will be osteoconductive because if it is cancellous, it will have porous surfaces. It will be osteogenetic. There will be osteoblasts in there. And if you do want structural stability, then you can go for your alia crest, or you can go for your fibula, or things like that. So it's up. That's why you need to know all these properties. And depending on what situation you're dealing with, you will choose one graft or the other. So this is why we're saying that an autograft is actually the gold standard, because it comes with all properties packages there. It's all there in one shop, okay? So the next question then will be, if the bone graft is the gold standard, why are we not using it all the time? And Ashley, you're off the hook. I'll find someone else. Blankson? Is Blankson in the room or is it just his name up there? Benjamin?
Yes,
Hey?
Jimmy, I'm here.
Ah, you're there. Okay, I thought you just switched on and then went to the kitchen.
Oh, no, not at all.
All right. Why are we not using autograft all the time? What are the disadvantages of an autograft?
It's short in supply. You can't find it all the time, and you may not have enough size to fill a defect if your defect is huge.
That's the short supply, isn't it?
Yes.
Yeah. What else? Why are we? What else? What else is the concern with autograft? Why don't we go to autograft all the time? What can happen if you're taking the Allog crest autograft? Do you remember Marie's case?
You can also increase morbidity because your site may get infected.
Yes. So the main problem for me, if you ask me, the main problem, yes, it can be short in supply. You can't get as much as you would like to have, but there is this problem of donor site morbidity, all right? And if we're talking of donor site morbidity, we're looking at nerve injuries. You can injure the nerve where you're taking your Allog crest, and you can cause infection, all right? And they have a lot of pain after the procedure, and they can fracture, okay? They can fracture. So these are the things that we tend to say it is an inconvenience, it is a problem. So we don't go to autograft all the time because of donor site morbidity. But otherwise, if you could, autograft should be your first choice, right? So, and depending on what you're doing, you will then choose where to get the autograft from. Okay, now I've got you there. I was speaking to Ashley just now. He mentioned a whole lot of places that you can get autografts from. Do you have another space you can get autograft from where you can actually get a lot of it? If you don't know, pick up your friend, we'll ask him.
Who else is on here?
So you don't know, you've given up already. Who is DBA?
A lot of it. A lot of one.
Hi, Jim, is Dalry here?
Ah, yes. How's it, man? Where can you get a whole lot of like BMPs and some cancellous bone and all of that? It's a technique that we don't often use, but sometimes we're using it without knowing we were using it.
With aspiration, so you can
ligament
artery aspiration.
Yes. So it's called. It has a girl's name.
Yeah, the name just slipped me. Sorry.
It's called RIA. You just said it. It's RIA. So it's reaming, irrigation, and aspiration.
Yeah.
And it comes with some specific device to do the procedure.
Sure.
You see. Okay, cool. So while I got you there, we're just going to talk a little bit about, so the first option, of course, we have established is the autograft, and we've said this is the gold standard.
Yeah.
But the next option we're going to move is the allograft, okay? So can you think of the advantages of the allograft?
So you get different types of allograft.
Yes.
Whether it's fresh, frozen, or sometimes it's froze dry.
Yeah.
Some advantages is you don't get the mobility.
Just quickly there, we don't use the fresh ones anymore just because of risk of infection and all of that. So we mostly use the frozen or the dry frozen.
Sure.
Yes.
The croutons. Look, you don't have that much mobility, obviously.
Yeah. So there is no donor site mobility. That's good.
Yeah, there's less risk of immune modulator, immunogenetic, how do I say,
So immunologic reaction, is that what you?
Yeah, correct. Yeah.
So I would say the freeze drying process does reduce the allergic reaction or the allergen in the allograft, but that risk is still there. That risk is still there, but minimal. And then the other advantage is that you get pre-shaped bone graft. Like if you just want a little small disc for a span operation or things like that, they come in pre-shaped allograft. I see Delroy, something happened there. But in any case, so those are the advantages. You have, they are quite in good supply as compared to the autograft. You get, and you get different shapes. You get different kind of them. Sometimes it's just cortical plates, like you can get a humeral plate, or you can get fibular strut. If you, cancellous bone is what you want, you can get calcaneus discs and all kind of shapes to fit the defect that you have. So now that Delroy is gone, I'm going to pick up Kim. Kim.
Hi, Dr. Kauta.
Hi, Kim.
Can you hear me?
Yes, I can hear you now. Can you think of any other side effect of allograft? The reason why we may not be very excited about them?
Risk of infection.
Yes.
Transmitted infections.
Yes, so risk of infection with the sterilization method they have now. So they either they freeze it, or they dry freeze it, or they gamma irradiate it to try and decrease the risk of infection and allergic reactions. But the risk of infection is still there. Anything else that we may consider, especially if we're using kind of cancellous type allograft? What happens to the mechanical properties when they're undergoing gamma irradiation?
So they have decreased structural ability. It affects the bone, the structure of the bone, makes it less amenable for osteo.
Exactly. So they become mechanically weak and may not be able to withhold the strains or the load. Once they've been fixing, it may take some time before, of course, hoping on the remodeling. So it's going to take a long time because they are mechanically weaker compared to autograft cortical bone. Okay, so that was very good. And so this would be then the second option. Of course, they are still in use. And like I said, about 9,000 procedures being done regularly. So you will be short of supply if you are using them a lot. If you ask Bone SA, there are times where you're looking for femoral heads and they tell you that the femoral heads are out of stock. So you still have to get bone from somewhere, and that becomes a problem. Even if we say the supply is not such an issue, it may become an issue. Okay, so I see Michael Abrahamson. Hi, Michael, can you hear me?
Yeah, I can hear you. How are you?
Yeah, good, thanks, man. So we've kind of debated the autograft, and we have debated the allograft. We're still talking in terms of properties, talking in terms of advantage and disadvantages. And now we're moving to the next available option, which is bone substitute. Because autograft and allograft is still bone. Eh? Now we're talking bone substitute. So with bone substitute, let's talk about the various ceramic options that we have. Can you remember any?
Sure, not very well, eh?
Okay, so the ceramic options we have are actually different composite of calcium. So you have tricalcium phosphate, that's one of it, and they all have different kind of mechanical properties depending on how they've been bonded. So you have tricalcium phosphate, and you have calcium sulfate, and you have calcium phosphate. So those are the three that are commercially available. Some of also I forgot to mention the hydroxyapatite. Eh? So they have different mechanical properties. An example would be tricalcium phosphate is mechanically weaker compared to calcium sulfate cement. So if you want to feel a defect, like in a tibial plateau fracture where you want to start earlier range of motion, you may want to choose to go with calcium sulfate rather than tricalcium phosphate. And the other thing is tricalcium phosphate get resorbed quicker than calcium phosphate, right? Which stays in the bone longer and gets reabsorbed very slowly over a period of time. So the hydroxyapatite, we also see it used in a whole lot of other implants, like you get HA, that's HA coated pins. You get some arthroplasty implants that are coated with hydroxyapatite because of its porosity. It's very osteoconductive. And then the last one is calcium sulfate. So with calcium sulfate, the problem is it has no porosities. So if you are ordering bone substitute, you just have to remember that calcium sulfate has no porosity. And if you put it in there, it's going to harden up. There's not going to be any osteoconductivity with calcium sulfate. So these are the properties you need to remember when ordering bone. And we will get to, when we start giving examples, we will get to ask a few questions.
Can I just ask, Jimmy, for these bone substitutes, apart from the last one you mentioned, that they basically only have osteoconductive properties. There's no osteogenic, there's no osteoinductive. They're just a space filler.
They are just a space filler, and because they are a space filler, you have to know which one has osteoconductivity. Like I said, calcium sulfate has no porosity, so you shouldn't be using it. But calcium phosphate and tricalcium phosphate, as well as hydroxyapatite, have porosity. So you can use those because of the osteoconductivity. They have no osteoinductivity. They have no osteogenic properties, none whatsoever.
Okay.
So these are space fillers. We use them in acute trauma. Especially, I've used ones around the tibial plateau. You have a defect, the rep is there with a nice paste. You put in a syringe, you fill the defect, and you put screws. So we will get to the applications just now. So, right. So the other problem with bone substitute is, like Omar mentioned, they have to be biocompatible. But the other thing is the cost. So we have to be, we have to make an effort to know how much it actually costs, because the same desired effect you will get from this bone substitute, you can get it from probably cost-effective or cheaper options like croutons and things like that. So you have to know about the cost, because some of these bone substitute, they can be costly. Supply is not an issue. They're everywhere. You can call for it. The reps will bring it. And they're also easy to store and easy to sterilize, which makes them a little more appealing and attractive to most companies and some hospitals. Okay, so these are bone substitutes which are ceramic based, which are like inert with no biological properties whatsoever. Now we are going to talk a little bit about, I wouldn't even call it bone substitute. I would call it biologically active proteins, which can induce bone formation. So which are osteoinductive, and those will be BMPs. So where is Chironga?
Yes, Dr. Kauta.
Yes, tell us about BMPs. Which ones are we really interested about or interested in?
I can't remember much, but I think bone morphogenic proteins. I think that there are different types, but I can't remember which types. But I think they are classed into type 1, type 2. I think, but I think the type 1s are the ones that we are usually interested in. But I can't remember much.
Okay. Yeah, that's fine. I was just trying to check that you were actually following and not drinking tea or things like that.
No.
But like you say, yeah, most of us, after we've written intermediate exams, we forget about what bone morphogenetic proteins are. It's things you don't see with your naked eye, so it becomes difficult to remember. But if that question came again for exams, it's BMPs 2, 7, and 6, eh?
Okay.
Yeah, these are the ones that are osteoinductive. And then, can you tell us a little bit more about demineralized bone matrix? What are the properties of demineralized bone matrix? Have you ever used it before?
Sorry?
Demineralized bone matrix.
Yeah. So with
DBM.
demineralized bone matrix, the way they are formed is such that you end up demineralizing the bone itself. So it still has some mineral component in it, but mostly at the end of the day, it works more like a osteoconductive material. Osteoconductive material, but it still does have some osteoinductive properties in it, but they are not as compared to the osteoconductive properties. But it's mainly osteoconductive.
I think you've got it the other way around.
Yes.
So demineralized bone matrix, actually what we are after with DBM is the BMPs it still has. So it does have still some BMPs. It's probably one of the easiest way to get some BMPs from outside is to get the DBM. And definitely, like you said, they are osteoconductive as well, but they do have osteoinductive properties. I think it is still quite expensive to have it. I have not ordered it in South Africa. I have not used it anywhere else. I've just seen it in the books. But yes, it is available. You can order it. Okay. So these are essentially our options. We've gone from autograft, we've gone to allograft, we've spoken about bone substitutes, ceramic based, and we've spoken about those with BMPs and everything. Does anybody have any questions at this stage? And we have also established that our gold standard is still the autograft, right? Does anybody still has any question, or should we move on?
Yeah, Jimmy?
Yeah.
I was going to ask, so like even you have classified them as your autografts, allografts, as well as bone substitutes. Do you also, as a subset include your growth factors as well as a topic or a subheading when you are talking of bone grafts on bone grafts as well?
Yeah, so when you're talking about growth factors, I would put them together with the BMPs, and they're all proteins and they have different names and they act differently. Okay, so you have the BMPs themselves, 2, 6, and 7, and then you have other growth factors like insulin-like growth factor or transforming growth factors, platelet-derived growth factors, or fibroblast growth factors. So it's a whole family of all those proteins that kind of play a role into stimulating undifferentiated pluripotent cells into becoming bone-forming cells.
Okay.
Yeah. So that's just to know. That's just for us to know. Yeah. Okay. So now we're going to talk. So just for this tutorial, just remember whenever you're thinking bone graft, because I'll be giving some few scenarios now. Whenever you're thinking bone graft, just think, what do you need from the bone graft? Because only an autograft is able to give you all the properties that you want: osteoinductivity, osteoconductivity, osteogenic, and structural support. So even with the autograft, not all of them will give you structural support. So when you're thinking bone graft, you have to think, what do you need and where can you get it from with least side effect and cost effectively. Okay. So Ayik, is Ayik still?
Yes, I'm around.
Okay, so you've seen a 36-year-old patient. He's not a smoker. He had both forearm fractures. You did open reduction internal fixation of the radius and the ulna. For some reason, the radius has healed, but there's pus coming out of the ulnar wound. The bone is not healed. The screws are loose. How are you going to manage that?
So we'll take the history, examine the patient, and
What is septic non-union of the ulna midshaft?
so septic non-union of the ulna, I would go in after I take the investigations, the all needed investigations from X-ray to the blood, and then take patients into theater, or will consent the patients for the removal of the plate and wash out, and then I will examine, see how much bone is lost, and then my options, if it is infected, I would take some samples for cultures.
There's pus coming out.
Yes, so I would just see what is the sensitivity microorganisms, and in this stage, I wouldn't put another plate till the bone heal. I got two options. The first option is to put external fixator to keep the bone aligned, to keep the bone aligned, and just put the patient on.
The radius has healed, eh? The radius has healed. It's only the ulna.
The radius has healed only ulna. So that is mean I would just put a back slap and then just the sensitivity, and put the patients on antibiotics, and then wash the wound every day. Watch the wound and see how it's gonna heal. After that, if I control, it.
Just let me stop you there. If you are in theater, so you're debriding this, eh? It's infected, you're going to debride, and you're going to have a bone defect, isn't it? How are you going to manage the dead space?
So the dead space here, I would manage it with the bone graft. So here
at the initial debridement.
No, not at the initial debridement, definitely, because here I'm fear of the infection. So
what are you gonna do?
So at the beginning, I would put a space filler, like cemented, cement with antibiotics. Fill the space.
So that's how you're gonna do your initial stage, eh? You're going to debride, and you're going to put some cement in there with antibiotic impregnated cement to fill the space. It also, you will put it in between the two bones, so it may also stop your bones from moving around, eh?
Yeah.
Your bones from moving around, and then you're going to get antibiotics directed to the microorganism you've cultured, and you're going to treat it for the appropriate duration, and you're coming back for the second stage when the infection is cleared. What do you do at the second stage?
So at the second stage, I would examine, see how much the defect is, from the beginning, I would have already background how much the defect is.
Well, the infection is cleared. You're happy now. CRP is down, ESR is down, white cell count is down. The arm is looking good. There is no seepage. Nothing is seeping through. You're inside. The bone looks great. What do you do?
So I'm thinking now the graft, whether I would use an autograft.
What are you likely to find? What are you likely to find at surgery with regard to your bone cement? What will it look like?
The bone cement would be covered with a membrane.
Okay, so there will be a membrane. There is likely to be a membrane around it, yeah?
Yeah.
Okay, and then what do you do?
So would take out the bone cement and keep that membrane in because it has a property of promoting bone healing later on. When
okay, that's good. That's good.
Yeah.
So you still have now a defect, isn't it?
Yeah, I still have a defect. So like I said, I would measure.
Let's make it easy. Your defect is about 1.5 centimeters. So
1.5 centimeters, I would graft it with the autograft, like it is.
What are the properties you would like your graft to have?
So I would like my graft to have all 3 properties: osteoconductive, osteoinductive, and osteogenic.
Only 3. What about the 4th property?
The 4th property is is a mechanical support.
Yeah, structural support, isn't it?
Structural support, yeah. Is that
the defect there? There's no bone around it. It's floating. You want structural support.
Yeah.
Okay. And how are you going to fix the graft?
So then I would fix the graft with the plate on top of, after I put the graft in, and then I can put the plate.
Where did you get the graft from?
I would take it from the iliac crest. Is one of the options, is to take the cortical iliac crest. Yeah.
Yes. So I like that option too, right? You get it from the iliac crest, you put it in there, and you use a compression plate, eh?
Yeah.
You freshen your margins, you have bleeding from the medullary canal, and you get a DCP, you line it up nicely, and you compress the bone graft into the defect.
Yeah.
Okay, so that is good. So you've used an autograft, which is the gold standard, and it has provided you with all 4 properties.
Properties, yeah.
Okay, cool. So Pravesh. Is Pravesh in?
Yes, I'm here.
How's it, man?
Good, I'm fine. How are you?
Good, man. Good. This is a 36-year-old guy. Was in a motor vehicle accident about, let's say 8 months ago. You did a femoral nail, size 10, and it's a mid-shaft transverse fracture, nothing else to it. He comes about 8-9 months. He still has pain. Well, you look at the callus. There's a little bit of callus, not so exciting kind of callus you want to see. How do you manage that? I mean, you expect the femur to have healed by 3 months, isn't it?
Yeah, so you said it was a mid-shaft antegrade femoral nailing.
Yes, size 10.
Size 10. So it looks like already it's an established non-union happening there. It's 9 months, it's not healing. Probably if we compare from previous x-ray, there might be no progression of healing.
Yeah.
That will be, we start with our host stratification, try to see what
he's a type A.
Yeah.
He smokes, but he's a type A, yeah.
And from the x-ray, we can assess what type of non-union it is. Is it a hypertrophic, atrophic, or oligotrophic? Is there some callus formation there? Or is it an...
it's in between. It's in between, Pravesh. It's in between. There's some callus, not so much, but yeah.
Okay, so we know for femur fractures, if you do an exchange nailing, we can get...
That's the word. That is the word. So that is the word I wanted to get from you. So what are the properties you can get when you look at the bone graft properties? What are the properties that you get with exchange? It is a sort of bone grafting, eh? All exchange rimmed nail, you're going to get some bone grafting there, isn't it?
Yes, we will get that.
From the rimming, yeah.
The girl's name, Ria, rimming
Yes,
irrigation
yes,
aspiration.
exactly.
Yeah.
So what are you getting from Ria?
So we'll get osteogenetic properties, osteogenetic properties, BMPs. I don't expect any osteoconductivity because we are rimming and we already.
And we will try and compress the fracture as well.
Yeah, and we are compressing the fracture.
The rimming in itself gives you osteoinductive and osteogenetic property, right?
Yeah.
Okay, easy case, Pravesh. That's done.
Thank you.
Cool. John Vogel. John Vogel.
Hi, Jimmy, I'm here.
Good, man. Are you dealing with a tibia fracture?
Oh, no.
Now, this is going to get a little complex now, John. Marit is in the room, I can see, and he's welcome to comment. So you have a tibia fracture. It was open, had an X fix. They lost some bone, but everything is clean now. The defect is 2 centimeters, and you want to nail it. What can you do about the defect?
Okay, so the different ways of managing defects, obviously, as you've alluded to, depend on the amount of bone loss.
Yes.
So up to 2 centimeters, I think you need to look at what sort of patient you've got, because you have the option of acute shortening. That is going to leave him with a 2 centimeter leg length discrepancy, and you could offer him a shoe raise. If that's not acceptable to the patient, then you can try some other things. So then I'd move up a level, and then my next level at 2 centimeters would be you could graft the defect. There's also, the name escapes me now, doesn't work so well in the tibia, but it can be done, where you use a cement spacer and then
The name is masculine technique.
The masculine technique, yeah, where you produce a membrane and then you bone graft inside.
Okay, you could do that. Okay, what if the defect was 4 centimeters? So you can't do acute shortening anymore, right?
Yeah, you can't do acute shortening. So now you can start looking at bone transport techniques.
Sure.
With circular fixators. You can still, it's getting long for bone graft, but you can still acutely graft it. Masculay still an option at that level.
So the one you got to the point I wanted you to get to, it was the masculay technique. With 2 centimeters, I'm happy you can acute shorten. 4 centimeters, you can go for a masculay technique. But what kind of, can you explain how does it work?
Yes, so the masculay technique, you essentially you putting cement, you're putting PMMA into the defect, to the void.
So initially, you use some sort of bone substitute. Yes.
Yes. So then you induce a membrane over that. So essentially a membrane grows over that. You then go back for the second stage.
Yes.
Where you remove that bone substitute, and you then put in a bone graft.
Yes. So what bone graft are you going to put in there, and what do you want from that bone graft?
Well, so now I've got a defect. Depends what I'm using for stability. So for the defect, I need it has to be a void filler. In addition to that, it needs to be osteoconductive, because essentially I need to get bone into that defect. It needs to be it'd be nice if it can give me a bit of structural support, because 4 centimeters is going to take a long time. Sorry?
Yeah, don't worry.
Yeah. Okay. 4 centimeters is going to take a long time to incorporate. So it'd be nice if you can give me some structural support as well. Otherwise, my hardware, whatever I'm using, might fail. And of course, if it's got osteogenic potential, that'll also
so
that's also going to help a lot.
Essentially, they try and pack a whole lot of cancellous bone in there, and then they rely on implants to maintain stability, you see. So it takes a long time, as you've alluded to. But again, these are just to try and show you the various applications of bone grafting. It can be easy as the ulnar compression plating with a little bit of piece of iliac crest, which you can do at Mitchell's plane. But it can also get complex, like a muscular kind of bone grafting, which you actually want to take to Maritz at Cruz Care Hospital. Do it with someone who's been doing it, who actually can give you tips on how to get it right first time around. Just to give you a perspective, the reason I brought this case up is to give you a perspective that it's not just bone grafting. There is experience involved. You have to be in centers that do some complex bone grafting for you to be able to do it, rather than just on your own. But everywhere you are, whatever you're dealing with, the principles remain the same. What do you need and where are you going to get it from, you see? So that was one case there. And then who can we get this down? Let's scroll this way. Omar, you did the talk.
Yes, Jimmy.
Okay, so you have a grade 1 Sotelo grade 1 protrusion. Oh, shucks, that's above your pay grade. Let's find someone who's doing others. Who's doing others? Where are the others guys? Where is the whoop? Is he on leave?
He's on call.
He's on call.
The whoop is on call. Okay.
Jimmy, you can ask me. You can ask me here. I don't mind. I might not know the answer.
Yeah, Vichy. Yes.
You well. Yeah.
Then so are you VB? Okay, cool. Listen, man. You have a Sotelo grade 1 protrusion, right? And you're going in for a total hip. What's going on through your mind?
So first of all, with the protrusion, you know that you've got bone loss, ideally, or on the acetabular side.
Yes.
On X-rays, hopefully you've assessed the femur as well, but your main concern is probably the bone loss in the acetabulum.
Yeah. So with the grade 1, the the femoral head is still in place. It has not migrated past the collar's line. It's still lateral to the collar's line, but then the flow itself is about 3 to 4 millimeter past the collar's line.
Sure.
So it's the easiest grade you get.
Yeah, my concern with doing arthroplasty or doing a total hip there would be with reaming the acetabulum, that you could possibly violate the wall and create a larger defect. So in preparing for the case, I assume, you know, as the principles that you've been talking about is to choose a graft, or to think about what graft you would use and what you would need to use it for. So with the reaming of the acetabulum and the floor itself, you generating good autograft, and you'd want to look at all three of those properties that you've spoken about, being osteoconductive, osteoinductive, and osteogenic.
Sure.
And I think from the reamings itself, you would tick all those boxes. And depending on how much you would get, you'd be able to use that. If you are doing total hip, you could then also use the femoral head that you've resected as autograft, and you know, if you needed more volume, let's say. Okay,
so that's the answer. So you want some cancellous bone there because your cap that you're going to use is either HA coated or a trabecular kind of metal, which can sit nicely on cancellous bone, and cancellous bone will heal to the pelvis and onto the cap. So if you go and put a piece of cortical bone there, which has not much of osteoconductivity, it's not going to grow into the cap. So that is another good example of when you think of grafting, you have to think about what you need, where you're going to get it from. You can get it from the rimming. The rimmings aren't that great because there's going to be a lot of cartilage on it. So you may try and separate it, but the femoral head is also a good place to get cancellous bone from. Okay, well done. So we moving on. Let's find Kim. Kim Lobsher.
Yes, Dr. Kauta.
Yes, you're doing a ACDF with Prof. Dan for a fracture. You want to do a fusion for a fracture, or let's say even for a disc. And for fusion, they usually use bone graft. So which bone graft are you going to give him?
Fibula strut.
So you're going to get
or caged bone graft.
Okay, so he want an autograft. You can get him a piece of fibula because it's small. You see, you don't need to go get an allograft fibula graft. You can get an autograft from the fibula. That's very good. But the fibula doesn't have much cancellous bone. They do want some osteoconductivity and all of that. Not just a structural graft. So you can also, fibula is a good answer.
Crest?
Yes. So fibula is good, but you can also get an iliac crest. And the iliac crest giving you a much larger surface, and you can shape it and fit it in as best as you can. Okay, well done. ACDF, iliac crest, or fibula, and what you want is structural stability because they're fusing it now. They want some support, even though they're going to put a plate on it. They want some support, and then it's going to be osteoinductive, it's going to be osteoconductive, and osteogenic. Right, cool. So, who's doing tibial plateau? Another example, I'm just going to go through examples now because I'm running out of juice here. So, another example where you can use bone substitute would be fracture repair. If you're dealing with very soft bone, or doing comminuted intra-articular fractures like tibial plateau, once you elevate the articular surface, you have a void behind. And then you can choose to fill that void. It's often not the big voids like 1 centimeter or 2 centimeters. You want something that's going to give you immediate structural support so it can support the cartilage. Then you can either go for an allograft in the form of croutons. You can crush them into there to support and then plate, or you can use bone substitute like calcium phosphate. It gives you almost immediate. It's in a form of a paste. You inject it in. After a while, it hardens while you're still in theater, and it gives you good structural support. So these are the applications where you may need to use bone substitute in acute fracture repair. Another example, which has not taken so well in the market, is using cement around hip screws. Like you're doing a PFNA, it is a Synthes product. The hip blade is fenestrated. So you can actually inject cement into the hip blade so that cement seeps out of the blade and anchors the blade into the bone to avoid cutouts and things like that for hip fractures. Okay, so I think we've covered well our objectives. And if you guys have any other questions, you can ask. It's about an hour. Otherwise, bone graft is quite a short and easy topic. You can make it as complex if you want to go into wide reconstruction options. But for tonight, I think that's what you will need to remember. Any questions, guys?